So I'm going to introduce our first speaker today, Sandra Billinger. Dr. Billinger is a professor at the University of Kansas and the director of the Research in Exercise and Cardiovascular Health Laboratory and the Neurovascular Division Director of the Alzheimer's Disease Center at the University of Kansas. She's a fellow of the American Heart Association, which means her professional accomplishments, volunteer leadership, and service are recognized by that eminent organization of cardiovascular and stroke professionals. She has practiced over 10 years in geriatric, neurologic, and cardiopulmonary physical therapy. Dr. Billinger has received continuous grant funding from internal and external funding sources, including the NIH, the American Heart Association, and the Cardiovascular and Pulmonary Section Research Grant of the American Physical Therapy Association. These grants have focused on cardiovascular health, exercise-related interventions, and how physical activity impacts stroke recovery. I'm going to stop sharing the screen. So Sandy, you can have it. Are you still a co-host?
I don't know if I am, but I don't think I need to be. Let's see here. All right.
There you go.
Yeah. All right. Well, let's see. It is afternoon for me and you. Keep having to look at my time. It's such an honor to be here today to talk with you. If you happen to be somebody with a physical condition and you were in the first talk, you might hear some overlap, but hopefully there'll be some good messages that you can take home and breaking down some of the information that we talked about earlier. Again, I think it's really important to emphasize, over the years, we've done so many great things for heart health and really what we know about exercise in the brain after stroke is really rather young in the research world. And when I first started my career, and it was in the late 90s, looking at exercise and stroke, it was really thought that exercise might not be good for people after stroke and that it could increase spasticity and tone. And so it was generally avoided for people after stroke. And we've learned so much over 20, 22 years that says that exercise, specifically my interest is in aerobic exercise, is really beneficial for people post-stroke, especially from the cardiovascular health perspective. But then I'm also very interested in looking at, how that might affect our brain health and specifically the vessels of the brain or cerebral vascular health. This is my funding, and I just have to list these disclosures. And so again, there's this idea that, how can we make our brain healthier? How do we prevent having memory issues, and not just after stroke, as we age? And so, what is the ideal optimal brain health? And I was really pleasantly surprised when I read this paper that all the things that essentially we can do for our heart is good for our brain. And I'm going to actually take some time to go through those. Although we are going to talk about exercise, I really want to highlight how all the things that we can do for our heart is good for our brain. So as we start out, as we work from both top down and then bottom up, I'm going to start up at the top. And so there's genetics and factors that we really can't control and that we're born with. And all of these things can either negatively or positively affect our brain health. And you can see that these intersect. This is our development from birth over our lifetime. And again, are we engaging in good, healthy behaviors, our social environment? Are we staying active, eating healthy, all of these things in our social environment? And then, we have exposures. And so for me, who grew up in Western Kansas, there's a lot of things such as pesticides and a lot of grain dust and things that are associated with farming that could actually negatively affect my brain health. So again, there's different environmental exposures that we can think about and choices that we make across our lifespan that can affect our brain health. There's also this idea of vascular risk factors, and this is what I'm going to spend a little bit of time talking about today, and some of these things that we can control and some things we can't, that are related to vascular health. And when we think about, for people living with stroke, these vascular risk factors remain even after our stroke, and we need to think about those in secondary stroke prevention. But when we think about these vascular risk factors, they do have an impact on the small vessels in our brain. We think about large arteries, like there's the carotid artery right here in our neck that goes up directly up to our brain, our internal carotid artery. We can develop atherosclerosis or hardening of the arteries. Any structural or functional injuries can have an impact. And then again, there's certain aspects of cardiovascular disease that lead to cognitive dysfunction, and that can be atrial fibrillation, where your heart beats, maybe a little bit faster, the top chambers of your heart. And again, your doctor's going to look for these, and then different myopathies and valvular diseases. And all of this can lead to cognitive dysfunction, which then has a decline on our optimal brain health. So, what are these vascular risk factors? So, if you visit the American Heart Association's website, they have a page, or you can Google Life Simple 7, and they'll go through and talk about, and we're going to talk about each of these today. But I do have a colleague that really focuses on sleep research, and if she's, would have an opportunity to listen in or check in, she'd be upset if I didn't talk about sleep, at least mention that. And getting a good night's rest is so very important for our body to recover in the evening from all the activities or maybe things that we do during the day. So there are some risk factors. Family history, we are born with that, and that is hard to change and something we can't modify about ourselves. However, as I go through these risk factors, even though we might be more likely than somebody else that doesn't have certain risk factors, we can modify those, but by making sure we're having a healthy lifestyle. Age, we all get older every year, so that's not something that we can change. When we think about blood sugar, you might hear the term blood glucose. Some people may say, my sugars are high, or we think about blood sugar. We think about, you may go to the doctor and they do a blood draw and have a fasting glucose. And so we want that value to be lower than 100, and that's what we call normal, or in this healthy range. And you can see that as these numbers go up, they put us at risk for diabetes. And I know Liz was talking about this earlier, and that people with stroke, spinal cord injury, heart conditions were at an increased risk of developing diabetes. So again, we want to watch this. And then when these values get higher, you might get a diagnosis of diabetes. And again, this puts us at increased risk of heart disease or stroke. Again, if you've had a stroke and don't have diabetes, we want to keep you active and watching your lifestyle and diet so that you don't get diabetes. But one of the nice things about controlling our sugars, our blood sugar, is that nutrition and watching our diet and exercise can actually reverse or lower those numbers to put us back in a healthy range. High cholesterol, there's a number that you'll get that's total cholesterol, and this is a large number that typically over 200 is where they start to watch those numbers. But you also have good cholesterol and bad cholesterol. So your good cholesterol, or HDL, which is also your high density lipoprotein, they're going to look at those numbers, and those are protective. And again, somewhere between 55 and 65 is a good range. And in fact, if you have a value in this range, it offsets any other, and one other risk factor. Or if this one's high, this good marker, if it's in a good range, actually crosses out this one. So it's good to make sure our high density lipoprotein values are high. The LDL, or bad cholesterol, you might hear about, again, we want to keep those below 100. So again, with high cholesterol, for people that might have a diagnosis, or if your doctor has suggested that your cholesterol is creeping up or the numbers are changing, A good lifestyle, nutrition, Mediterranean diet, eating a lot of fruits and vegetables, especially the vegetables, and exercise actually can bring down your cholesterol values. Exercise itself actually increases that good cholesterol. So again, exercise has that protective mechanism. High blood pressure, for those that may not be aware, high blood pressure is often considered the silent killer. A lot of times we can't feel that our blood pressure is going up. Sometimes it creeps slowly over the decades. So if we're not going to the doctor or getting our blood pressure taken, we may not even know that we have high blood pressure. So recently, and so if a lot of times things change. I put the link right down here at the bottom so that you can look at these new guidelines. But in 2017, they came out with these new values. And so again, it's so important to talk to your doctor because there is some variation and some overlap here that you really want to get a good sense from your doctor. But now they're actually defining normal as less than 120, and this would be the top number in your blood pressure, and less than 80 is the bottom number, what we call the diastolic value. So we want it less than 120 over 80. They call it elevated as between 120 and 129 or less than 180. Or I'm sorry, less than 80 millimeters of mercury. And so again, depending on your doctor's position, they may still be okay with this. They may say, yeah, you need to watch it. Let's try to get it down to this optimal range. And they may or may not, probably not likely put you on medication here, but they want awareness there so that people are having conversations and asking their physician. Stage 1 hypertension, these are again, you can go through and look at the values. Stage 3, and if you ever have a hypertensive numbers that are higher than 180 over 120, so 180 over 120, you should see a doctor immediately because this really puts you at a higher risk for stroke. And we don't want that. So again, please check your blood pressure. This is something as a physical therapist I always talk to my patients about. I would always check blood pressure. It's just such an important indicator of overall vascular health. But for hypertension, again, a good diet, low in cholesterol, exercise, which will help lower blood pressure, the exercise and increasing our heart rate and that blood flow that goes through those vessels actually has some what we call vasorelaxation to the vessel, which means it relaxes more so that our blood pressure can come down, and that actually decreases the amount of work that our heart has to do. And so that is all good for us. For smoking, for individuals who smoke, we really recommend that people stop smoking. I know this is not an easy thing to ask people to do. Certainly there are smoking cessation programs and education materials. There's groups in which people can participate in for support to help you with that. The American Heart Association has this list of risk factors with smoking. It's one of the most preventable alongside physical inactivity, cause of death in the US. There's a lot of research looking at vaping and e-cigarettes, tobacco products. And again, I think this is important that it's the most preventable cause of death in the US. That said, the bottom mark, within 1 year after quitting smoking, your risk of heart disease goes down by half. So again, very important. Body weight, again, as you start to exercise, you might lose some weight, but also gain some muscle mass. So the scale's not the only index that we want you to look at, but thinking about your BMI. And this is how your weight and height are related to each other. And there's calculators out there. You can Google BMI calculator, and it'll calculate whether, that number, and then it tells you whether you're in a healthy range, overweight, or obese. Nice about body weight, nutrition and exercise is still another way to help decrease our body weight and keep us healthy. And then inactivity, sedentary lifestyle. Again, all adults, regardless of disability or not, should get 150 minutes of moderate intensity aerobic activity. And we'll talk a little bit about intensity here soon, or 75 minutes of vigorous activity. Again, you should always consult your doctor, healthcare provider, physical therapist. You might see a physician's assistant, nurse, and talk to them about the activity before you start. Muscle strengthening activity. We're going to talk all about this in relation to stroke, but this is important. And I also want to highlight the sit less. And move around more throughout the day. While it may not have necessarily great cardiovascular benefits, which there is an intensity component, but the more you move around, there are health benefits to that. And so again, try to reduce the time that you sit during the day. And again, the only way to change inactivity or sedentary lifestyle is to exercise. So, I just want you to take home, all these things that have been put in this American Heart Association presidential advisory, is that what's good for your heart is good for the brain, and they're linked together. Any questions, just briefly, Liz?
I don't see any questions in the chat box.
Okay.
I was just going to ask one question myself, which is, do you have a recommendation for people keeping track of you're mentioning nutrition along with exercise. I didn't know if you had a quick recommendation for keeping track of diet nutrition.
There are a lot, so I'm not a nutritionist, but I know there's a lot of apps and nutrition trackers out there. I've tried several of them, and I find it, for me personally, I find it difficult for me to log everything. There are some apps out there that allow you to take pictures of your food, and it'll give you the calories. But I don't have the names off the top of my head. I'm failing, Liz, in the nutrition area here. But I know that there's a lot of apps. I wish I could go over to my Twitter feed, because I know there's been some discussion on there about activity and which ones people are using. And I know there's a lot out there that can be, but I don't have a recommendation for which one is the best.
Yeah.
I think simple is easy. I think a lot of people with disabilities like where they can take a picture, so they're not having to type a lot, and that gives them opportunities to track their food intake as well. But thank you for the question.
Sure. Thank you.
So I do want to highlight, and I highlighted this earlier, and I think this is so important for us to always keep in our mind, and that, if we could take all of the benefits that we can package into a single pill, that if we could take everything exercise does, it would be the single most widely prescribed and beneficial medicine in the nation. And that's a pretty powerful message at all the great things that exercise does. And I know it's hard, because a lot of people will say, well, I don't like to exercise. I don't like to get really sweaty. I don't want to go to the gym. And you don't have to do those things. And again, we're going to talk more about that, but I just always want to put that out there. So the recommendations that I'm going to talk about for physical activity and exercise for people post-stroke actually comes from this recommendation, in which I was the lead author and chair of the work group, where we put this all together to talk about for trying to improve overall health for people living with stroke. And so we're going to go through this, because I think, we've done a lot of various surveys of physical therapists and healthcare providers. And a lot of times what always comes up is, I'm not really sure how much to prescribe. I'm not sure, people a lot of times can do the 3 times a week or 150 minutes a day, but they sometimes don't always know about that intensity. Like, where should they be? What type of medicine, if we think about this, or exercise? Should I do aerobic? Should I do strength training? Should I be on a bike? Should I get on a treadmill? Can I go for a walk outside? And so these are things that we often need to think about. And where I have down here this FIT principle, excuse me, this is really targeted at the frequency, which is how often, the intensity, which is how much, the time, like how many times should I take this per day, and then T is type. And again, I'm going to break this down for the audience. So for the frequency, and I just would like to point out that these recommendations are based on what we recommend for all adults. And this is the 3 times a week with activity on most days and to try to reduce our sedentary time. We don't have enough research specific to stroke to really say what helps with recovery, what might help you walk better. And so there's a lot of research now that we have the exercise piece, like how much should we do for recovery? And that's a really new area and expanding area of research in for people in stroke, because we can look at that across recovery, which is important. But I would like to say that it's so important to reduce your sedentary time. If you can spend the time not sitting as much, even taking bouts of, if you use a wheelchair most days and getting up is difficult, or moving on some type of exercise device, standing up and just not being sedentary is good. If you can hold on to a chair or a cabinet and you can do some squats and go up and down, anything is really better than being sedentary for overall health. So, again, to benefit our cardiovascular system, to make a really big impact on our blood pressure, and thinking about some of those measures, we need to think about this intensity in this range. And this is 40 to 75% of our aerobic fitness, or more like 30 to 65% of our heart rate max. And so I'm going to talk a little bit about this. We do really do recommend that, 20 to 60 minutes has been recommended for quite a while for getting in our aerobic exercise, that 150 minutes to meet that per week. However, there's a lot of research that shows that if you break it up, even during multiple bouts, if you did 10-minute sessions or 25-minute sessions, just breaking that up and moving around is very beneficial. So, intensity, this how much, is typically the most challenging task when we do an exercise program and when we design it. And this is a little bit because it requires individualization. So, all of you are very different from each other in that what your mobility might look like, whether you use a wheelchair, whether you use a cane, whether maybe you have no motor deficits after stroke. Maybe you have upper extremity deficits, but no lower extremity. So this requires us to think about how we prescribe this exercise to you, or how you choose to do your activity. We can express this as a percent of peak capacity. Again, you can think about it as if you had a stress test, you can think about heart rate. If you've done a metabolic test where we measure the air that you breathe in out, this is another way to do this. Um, or we can monitor your intensity during the exercise using heart rate. The work that you're doing, maybe this is the treadmill speed, if you're using a bike or a recumbent stepper, such as a new step. Um, we can look at the workload, and then we're going to talk a little bit about rate of perceived exertion, or how you feel during that exercise bout. And this is a really common way that I prescribe exercise for community goers. In Kansas City, we have a place called the American Stroke Foundation, which I do a lot of talks there. And a lot of times they'll use the RPE because they don't have access to all of this. But I want to share with you how we can look at heart rate. So if you are interested in using heart rate to prescribe exercise for yourself, that you can look at this. So you can take 220 minus your age. This is the most common formula to use. And then if you say, well, I've been reading in the literature, or I've seen on the American Heart Association website, I should be at 65% of this 220 minus age. You would take your age. So if it's 70, you would take 220 minus your age and get 150, and then you'd take that times 0.65. And that would be the upper threshold of what you would want to exercise at. There's also a formula that people like to use, that's 208 minus 0.7 times your age. And that just lowers it down a little bit, because we're not certain that 220 is actually our max heart rate. So again, I think, either one of these are fine to do. Always talk to your physician because medications can affect your heart rate. You can monitor your breathing, especially if you're on medications. If you're familiar with your medications, a beta blocker that keeps your heart rate lower during exercise. And so you might think, well, I'm using these formulas that I learned about in this talk, but my heart rate's not going up and I'm working really hard. It's important for you to know what medications you're on and talk to your doctor, because that might actually affect your heart rate. And so you'd have to use another method, which is going to be that RPE. So when we think about rate of perceived exertion, I always talk about the 6 to 20 scale. Some people want to use 1 to 10. And so we can talk about that if you have questions about it. That's fine. But 6 is on the lowest end. That's like not doing much at all. And then it goes up to 20, and I'll show you that here shortly. But 12 or 13 corresponds to somewhat hard and has really been shown, and there's probably a little bit of variability in this, to be about that 60% of that heart rate reserve. Whereas the RPE of 16 is hard, is getting close to that 85%. So this is working definitely much harder. And so again, thinking about where you are on this scale. So if you think about, this scale, the blue is very light. So it's how you feel when you're lying in bed or relaxed. You might be walking to the refrigerator, walking to the bathroom. Again, this would require little or no effort. And again, this is going to depend on disability, because I know that there's a lot of people that I've worked with who walking to the bathroom is somewhat hard for them. And again, just make sure that you're thinking about how you're breathing or how you feel during this exercise. But very light would be doing hardly anything at all, where you really don't even notice you're breathing harder. Whereas somewhat hard is that this is where you'd want to be for your blood, but to benefit your blood pressure, to think about blood glucose, think about weight loss. Again, this is where your exercise or your activity should be, in this somewhat hard to hard range. I feel that unless you have some guided prescription, some people always ask about high intensity interval training. I feel it's very important to talk to your healthcare provider about that before you start this, because this is getting up into this hardest work you've done. The maximal effort is where you're pushing yourself to, I just can't go any harder. This is it. We don't want you to be in these ranges. But this green zone right here, this 12 to 16 is where we really want you to be. And you might say, well, it's really hard to know what this number should be. What if I've never exercised? I might not know what a 12 would feel like. So we're going to talk about the talk test. And I think this helps a lot of people when they're not sure how to gauge their exercise. And the talk test is that if you are walking like these individuals are here, you should be able to, at these low intensities, be able to talk and sing. So if you can sing a song, not in your head, but actually out loud while you're doing your exercise, you can talk and you can sing a whole song and you don't feel short of breath, you're probably going to be in this light zone or this blue zone. If you can do your exercise and you can talk to somebody, but you're breathing hard, you won't be able to sing. You're going to be in this green zone. And if you can't talk to your neighbor or carry a conversation and you can't sing, then you're working too hard. And try to get back down to this green zone. Exercise type, again, these are some pictures from my lab. You can ride a cycle. This is a seated or recumbent cycle. We have treadmills. We have a harness in my lab. This is not a picture from my lab, but sometimes you might see, maybe in rehab, you were hooked up to a harness for walking. We have a lot of new steps in our lab, or these recumbent steppers. It makes it easy for people to use who may have balance or low extremity deficits. We can attach your hand to this device to help with your arm placement, or you can just use your legs only. You can also, if you have hemiparesis and maybe you don't want to exercise your leg and arm, you can exercise one side at a time. So any type of stepper, it doesn't have to be the new step, but any type of stepper. And then just going out and doing activities that you like are also very, very important. And this is always much funnier in person, but this is not how we can walk our dog. So usually I get a few chuckles out of the audience as this is not a good way to walk your dog. We prefer this type of activity, but I always still show it for fun because we're gathered here today. And so I wanted to share that. So you might have some questions about high intensity exercise. You might read in the literature that, well, people with heart disease are doing this, younger people are doing this. This is the new rage. There's, different gyms that talk about it in Kansas City. And I don't know if Orange Theory Fitness is in Louisville, Kentucky, or in your area. But some of these groups really target that high intensity. And is it safe for people after stroke? And I would answer that we just don't know. There are some benefits to that. You improve your overall fitness, and this is what VO2 max is. This is your overall cardiorespiratory or aerobic fitness you might hear, or your overall fitness. Those are some words that people might say for VO2 max. But what's helpful for people is the less training time. You get more benefit with less time. But what we don't know, there have not been in the literature a lot of adverse events, which means it's bad for you reported. However, we've really never done a large feasibility trial looking at the safety of this in stroke. But as research comes out, we hope to have more information for you. And it's also important to think about, can you, as a person living with stroke, adhere to this HIIT training? Can you get your heart rates up into these zones? And again, we just don't have enough evidence for that. But I would like to say that we did start a trial in January of 2018 looking at what is best for people living with stroke. Is moderate continuous training, that reaching that 150 minutes a week of continuous exercise, or this high intensity interval training? What's better for you with your walking after stroke? And it's still ongoing. We won't be done for about another 2 years, but Delaware, our site at KU, and then Cincinnati are the 3 sites, and Cincinnati is the primary site. But we want to really find out what's the optimal locomotor training or walking intensity that benefits walking capacity. And then how long do you have to do it to benefit? Is it 4 weeks, 8 weeks, or 12 weeks? And we just don't know the answers to those questions. So this is just what it's going to look like. I just wanted to share with you in case you are interested in what our study design looks like. We're trying to keep everything the same when they come to our labs in between groups. One is going to be in this continuous and one is in this max speed interval, and this is considered vigorous exercise. And this is just what the sessions look like. We measure their fitness, your fitness in between each session. We look at your walking performance. We're asking questions on how you like the intervention, how you feel about it. So there's a lot of questions that we're asking during this training. And again, you can see some of these. We're looking at fatigue, depression, a lot of different things. We're measuring people's activity, what they do once they start an intervention. Do they start to be more active? So again, these are important things for us to keep track of. So again, I just want to summarize, and I'll take a moment for some questions if you want to type those in there. Or I think Liz talked earlier about closed captioning and how to use that if you needed to. But again, aerobic exercise is important for overall health. I think it's important for you to understand that, not only is it just good for our overall health or our brain, but there's specific components of your risk factors that exercise really targets. So again, your sugars or blood glucose or blood sugar, blood pressure. Again, we want to make sure we are avoiding that silent killer and making sure our blood pressure is under control, both with exercise and medications are important to make sure you're taking those. And for your cholesterol and overall weight. And again, sometimes people will ask me, well, what is the best thing that I can do, like to help me after stroke? And really the important message is the one that you're going to do, because I can tell you to do exercise at a certain heart rate range, but if you don't like it, you're not going to do it. And so finding those things that you really like are important. I'm going to go over some muscle strengthening and some flexibility. I'm going to talk about that here shortly, but I want to see if there's any questions on this aerobic exercise piece. Liz?
Yeah, so Sandy, there aren't any in the chat box right now, but I have a question. And I also want to, if someone wants to ask a question verbally, if you look down at your the menu on the bottom, you'll see reactions to the right. And if you want to hit one of the reactions, like a thumbs up or a clap, we can call on you if you don't feel like typing it in. But my question, Sandy, is about I guess there may be two questions embedded here. If you are exercising and you should do at least 20 minutes, does that mean 20 minutes in that zone? So you might be warming up to get to that zone where you're having a hard time. You couldn't sing, but you could talk and be breathless and stay in that in 20 minutes and then cool down, or does it warm up and cool down included in the 20 minutes? And then if you're doing that, aren't you presumably building endurance? So you might have to work, increase your intensity on the new step instead of doing the exact same thing over and over again. Is that right?
Yes. So for your first question, typically we talk about the times that I gave you, that would be in your zone. So again, if we recommend the 20 minutes is what you had said, we usually have people just do a light warm up for 5 minutes or however, kind of get your muscles loose, makes you feel good for that moment. And again, probably in that talk and sing phase. And then we want you to be 20 minutes in that, that time, which you're in that I can't sing, but I can talk. And so that's the zone. And then we would do a cool down on the end where again you'd be in that talk and sing phase or that light. But if you can't do 20 minutes and you can do 10 minutes and you do a short warm up and your cool down, I mean, again, it's important not to get frustrated, think, well, I can't do 20 minutes. This isn't going to benefit me. 10 minutes, if that's where you're starting, that is great. If you have to shorten, if you feel like, oh gosh, I'm too tired, I want to try 12 minutes today. But I'm gonna have to shorten my cool down. So maybe do a warm up, 2 minutes of a warm up, and maybe you're gonna try 12 minutes of exercise and you feel great and you need a longer cool down. I mean, those things are all fine. And it's important, as Liz just asked, again, the more you do it, and it takes time, then you can build on that. So maybe you start with 12 minutes and that's what you can do. And the next week, maybe you try 13 and you can't. That's okay. You go back to 12. Maybe the next week you surprise yourself and you're like, oh, I went 14 minutes. This seemed easier. So again, you want to increase that exercise time. Now, you don't want to be, you might say, I'm not doing 60 minutes of exercise. I can't even do 45 minutes. So maybe you increase that intensity. So maybe you increase that resistance just a little bit, that you can maybe start with that 12 minutes of exercise and then continue to build. Does that answer your question, Liz?
Yes. And this is shown to improve people's health, even separate 10-minute bouts. If you do 10 minutes in the morning, 10 minutes the afternoon, 10 minutes in the evening, you've gotten 30 minutes in that day, right?
Absolutely. Yes, it is. Yep. Yeah, so it's and in addition to that, so again, those are great take-home messages, is that if you're getting those smaller bouts, even if it's 5-minute bouts, those are good. But you want to then not sit all day long too and think, well, I've got in my 30 minutes, I can just lay here on the couch. So or sit in the chair. And again, this is assuming that individuals are mobile. I'm giving cases in mobility. So if you can move around during the day and not put yourself at a risk for fall, but you have the ability to move around, I think that's great. Again, for people who are using a wheelchair or other modes of seated for their day-to-day, or maybe they don't have a choice because of the mobility issue. Again, we're not saying that you can't do different things. We have to modify it. So I gave the example of maybe having somebody, significant other, caretaker, help you with standing, and just standing throughout the day. That is going to provide overall health benefit. If you can get to a place where you can exercise or move your leg or do sit to stands where you're going up and down, all those things are still going to benefit you. And so This isn't to imply that if you use a wheelchair that you can't do exercise at home or try to find some ways. We certainly want you to do standing or marching in place. Weight shifting, just to kind of move and change that blood pressure and the leg activities. And also you can do arm activities. That might be something. So I just want to make sure that I'm being inclusive and thinking across different mobility ranges. And if anyone has some specific questions, because I haven't touched on maybe your specific disability, I'm happy to answer that question at the end of the talk. And I want you to make sure that you feel like I'm covering things that are pertinent to everybody on this call.
Sandy, there is one more question.
Okay.
What are your thoughts on the idea that doctors should prescribe a specific episode of guided exercise following CVA, similar to what physicians do for cardiac rehab? Should this become a standard protocol following CVA?
I would love that. There are a lot of places, and the US is not the best at it. I feel like Australia and Canada are really honing in on this idea of starting exercise, even in inpatient rehabilitation. There is some good literature out of Canada. They've tried modifying cardiac rehab programs in the U.S., Stacy Fritz's team at the University of South Carolina is also looking at modifying a cardiac rehab. I would love nothing more if insurance companies, after a CVA, would pay for cardiac rehabilitation to help people learn what exercise they need to do. If we have ability to come together and advocate and to work towards this, this is something I think would benefit people post-stroke tremendously.
It's one of our goals for our organization as well.
Yeah, well, we need to find ways to have a big voice and work together. So if there's things that your group is working on and that we can pull large groups together to try to advocate, I think that is so important for us to do. But,
Great.
For us that are researchers, we still need the evidence and we got to keep pushing this forward. So I'll do my part. I'm happy to pair with anybody and make a difference. So, all right. So I'm watching my time here and I'm going to have to hurry. Muscle strengthening. Again, some of these, this was just a something I could find on yoga. Again, not everybody's going to be able to do down, the dog pose or even lay on the floor for a bridge pose. But again, there might be yoga. I just wanted to talk about this in stroke. Tai Chi, there's different ways to do this, from seated positions in a wheelchair that you might be able to do some of them. There are different things and classes that you can take that are available for people who are wheelchair users or maybe who have limited mobility. Yoga is really great to do. For strength training, again, if you're a wheelchair user, there's hand weights and things that we can get from home, and TheraBand. I was trying to find some exercise from TheraBand, but I couldn't access everything that I wanted. But there are things that we can do from our wheelchair, or you can go to a gym. And again, I know there's various places that you can go that have modified equipment for strength training. Again, this was something that this is a kind of a very familiar for anyone that's maybe a physical therapist on the call, using the stretching bands. Some people have them tie them to the wheelchair and to be able to do the arm rotation, again, moving your arm in and out. There are bands, again, hopefully your physical therapist, occupational therapist, physician, nurse practitioner are talking to you about these things. Again, as with all older adults, we want you to work your major muscle groups. Upper extremity strength is so important for picking up that gallon of milk. Maybe it's your coffee cup, pouring your coffee, different things like that. When lower extremity strength is so very important. When I teach the physical therapy students, I always tell them lower extremity strength is so important and we have to work on this because this affects mobility. Getting up out of a chair, getting up out of a wheelchair, off the couch, we need that leg strength to be able to do that. So that's something I always encourage my students to work at. Again, 1 to 2 times is great if you can get that in. This is just what's recommended. the intensity, 2 sets, 1 set, this is all fine. This is just what's optimal. But again, this is not to say that if you did 1 set of 15 reps, that I'm not saying that that's not beneficial. Anything that you do is positive for your overall health. And again, you have to find what works best for you: weight machine, free weights, or TheraBand. And sometimes I will share, and I don't want to make this about me, but I was in a really bad car accident when I was pregnant with my son, and I used to be a dental assistant. I wasn't even an academic, and so it changed my whole life. I had a disability in my arm, and I couldn't do that, so I started with soup cans. Like, that's where I started. I was like, I had been very active as a teenager, and I started with soup cans. So anything is better than nothing. So don't think that you can't find something around the house to lift to do that. There's muscle strengthening. So just be aware that if you're going to lift, that there is going to be some muscle soreness associated with this, because you're breaking down muscle tissue in order to build it up. And it's called delayed onset muscle soreness. It may be 1 or 2 days after you do your exercise. And you might feel sore, like, ooh, I feel like I did something. There should never be pain. So just make sure that if something is painful, where you're just like, oh, now I can't move, and it's different than soreness, where it's achy, we should not be in pain. So whatever, just make sure you don't lift so much that you're in pain. I just always try to tell people that. And then we can modify this. And again, work with your physical therapist, occupational therapist, talk to your physician. Typically some activities are done in standing, but could you do it in a seated position, especially for balance and posture? And stretching is so important. If you have a lot of tone in your arm or your leg, having help stretching your muscles or doing it yourself. Again, you should not be stretching to the part of hurt or pain. It might feel a little bit uncomfortable, but again, you should be able to hold it there and not wince or try to pull away. So make sure you're stretching in your available range of motion. Don't try to make your shoulder move where it can't move. That's not going to be good, and you're going to end up feeling, something's going to hurt. And then again, modifying our stretches. For those that might have some hand weakness, again, there's balls that you can play with, putty, there's TheraPutty, there might be little bands that you can use to help you for exercise. Again, this isn't going to change your overall fitness, but it gives you that strength for gripping and grabbing, again, getting to a point where you can do functional activities such as, picking up a milk carton or maybe that coffee cup. So exercise, there are benefits after exercise, of exercise after stroke, and there's so many more than what I have here. I did want to share just with you very briefly. This is a little bit on some of the science that we're doing in our lab, and so we do have people after stroke that come into our lab and actually are willing to let us set this up on them and to do this activity. And so what we are doing is that we're measuring their brain blood flow both at rest and during exercise. And Liz, if you remember from this morning, she was smiling in the first picture and not smiling here. Yeah, she was happier earlier this morning. And then we measure their heart rate and we measure their blood pressure. And so one of the things that we are trying to do is really understand how, when you go from this resting condition, or where we're measuring you at rest, how does this change? So this is the blood flow in an artery in your brain that we can measure, and we can look at how this changes with exercise. So these are 15 younger adults, and this is what their blood flow curve looks like with exercise. And so if we look at like this measure right here at this time point, it's higher than these older adults. And so that happens with age. But these individuals were sedentary. We do have some data with similar older aged adults where they are physically active, and their data falls right in the middle. So exercise is very good for brain health. And just to show you this, I'm not going to talk about all the things on the graph, but what I want to show you again, this is 67 people aged 20 to about 80, 85 years of age. And so again, this low intensity would be the talking and singing range, and this moderate intensity would be the talking only. And so you can see that both of these exercise, so here would be when they're exercising at a steady state pace, they're just going. Right here is when they start exercising. So you can see how blood flow to your brain goes up. And we would expect moderate intensity to have more blood flow because we're working harder. But what I want to say is here is baseline. So look at the change from just sitting and doing nothing to actually exercising at that low intensity, that walking comfortably and doing things actually improves, shows that there's an increase in blood flow. Now, this isn't saying that I'm not saying that we've done an intervention and that it's better for you. What I'm saying is blood flow to your brain, which we want to get good oxygen to that brain, is better than sitting all day long. So no matter what you do, whether it's low or moderate or vigorous, you're going to have an increase in brain blood flow, and that's good. So for people post-stroke, we're really trying to understand how exercise helps brain health. It's very understudied and specifically relevant for people post-stroke. We have to understand how these cardiovascular risk factors that we've talked about will affect your brain health, especially the blood vessels in your brain, and reduce a future stroke. And my lab is also very interested in how we prevent memory changes, vascular dementia, or Alzheimer's disease in people after stroke, which is very important. So I'm just going to go through this briefly because we're about out of time. But we did this study to look at the blood flow response, and this is what we call the MCAV. And this is the blood flow velocity in your middle cerebral artery. And so I'm just going to skim through these because I just want to show you that the primary finding of the people who had the highest response and the people who had the lowest response, their physical activity and their overall fitness was what was significantly different. We even looked at, and I didn't say in the earlier talk, like what treatment they got, whether they got TPA, the clot busting drug, whether they had the clot removed. Everything was the same. The lesion sizes weren't different, but it was about physical activity that was very important. So again, you can see these differences. The darker circles are people who were more active. You can see that there's a better blood flow response than the people who are less active. So again, my lab will be looking at, if we do an exercise intervention for people post-stroke, could we increase blood flow? And whoever asked the question about that cardiac rehab program immediately after, imagine that and maybe those differences that we might see. I also wanted to share that the change from 3 to 6 months in their blood flow, if they had a positive change, that was also related in a positive change in their overall fitness. And if they had a decrease in the blood flow to their brain, it was actually related to a loss in fitness, so that maybe they were doing activity earlier and then didn't. So this is an important take-home message for being physically active for stroke. So exercise is great for everything. It's very powerful medication. It improves fitness, our brain health, and our vascular risk factors. And so I just want to thank, I forgot to add Liz on this, and everybody that invited me, for everyone in the audience, and all of our team members that we collaborate with. So I can take questions at this time.
Great, Sandy, thanks. It's so valuable to have such practical information and also practical evidence of the import of even, less than moderate, just moving at a lower level, and the improvement that it makes. I'm not seeing questions right now.
Okay.
Oh, wait a minute, wait. Another question about whether the PowerPoint slides will be available for download, or at least some of them could be. Sandy, you may want to think about that, or you may want to answer now, but that's a question we had from the last set of talks too.
Yeah, I already sent you via email because you sent me that email. So I've already, and if anyone's on from this morning, I do have to take out certain pictures, and especially of our unpublished data, I have to remove those because they're under review by the journal. But I'll send the handouts, and then you, Liz, if you want to coordinate with people and try to send those, I'm happy to do that.
Yeah.
I just might have to remove some pictures, probably not from this handout, but from this talk. But I will take out probably the unpublished blood flow stuff in stroke.
Great, great.
Yeah, yeah.
Well, so there are three things now I want to do. Oh, you stopped sharing. Okay, good.